Welcome to the GeriPal Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we got another Deprescribing super special with us today.
We have a full house to talk about Deprescribing. We're still working on this issue. We have not solved it, apparently. Our first guest is Emily McDonald, who's a physician in general medicine and epidemiologist and associate professor at McGill. Emily, welcome to the GeriPal Podcast.
Hi, thanks for having me.
Great. And our next guest is Amy Linsky, who's a physician and researcher at the VA Boston Healthcare System and associate professor at Boston University. Amy, welcome to GeriPal.
Excited to be here. Thanks.
And next we have Connie Fung, who I know well through the Beeson community and is a physician researcher, professor of medicine at UCLA. And we were talking about the fire situation there. I'm glad that's starting to resolve. Connie, welcome to GeriPal.
Thank you. Great to be here.
And our last guest is Michelle Odden, who we know well, used to be here, is now an epidemiologist and research scientist at the Palo Alto VA and is associate professor in Stanford. Michelle, welcome to GeriPal.
Thank you for having me.
All right, we got a lot to cover. Before we do, we always start off with song request. Amy, do you have the song request for Alex?
How about Just Like a Pill by Pink?
Why did you pick this song?
I mean, in addition to the lyrics being pretty spot on, I kind of wanted to see Alex singing Pink.
Yeah, this is a good challenge. Love it. Here we go. I'm lying here on the floor where you left me. I think I took too much. I'm crying here. What have you done? I thought it would be fun. Can't stay on your life support, there's a shortage in the switch. Can't stay on your morphine, cause it's making me itch. Said I tried to call the nurse again, but she's being a little rich. I think I'll get out of here, where I can run as fast as I can, to the middle of nowhere, to the middle of my frustrated fears. And I swear, you're just like a pill. Instead of making me better, you're making me ill. Just keep making me ill.
That was perfect for this
Yes.
Deprescribing super
Just keep
special.
making me ill. I had to make one little edit there. I changed a word. Some of you may have noticed. I think
It's
that's
the new
better.
anthem for Deprescribing.
Yeah, that's right.
I didn't notice. I'm not a Pink super fan. So
Okay. There was a word about, I tried to call a nurse again, but she's being a little... I changed it to rich.
Okay, this is like our, fourth Deprescribing super special. We haven't figured out why is it so hard. Well, I guess the question to all of you is, why is Deprescribing so hard? It seems very easy to prescribe medicines, and we do that very well. Why is it so hard to deprescribe, in your thoughts? Who's up for taking that one?
At the risk of repeating what you've had said on your prior Deprescribing ones, it's hard to undo things. And the analogy that I always give with Deprescribing is the idea of cleaning out your closet. Like, it sounds like a great, rainy day activity. You take everything out, but then somehow your prom dress still ends up back in the closet because you might need it one day.
That's the hard thing, right? Like, I've seen a lot of benzo deprescribing interventions, and while it may work during the intervention, 6 months, a year later, a lot of people are back on it.
Yeah, there are so many forces acting against us, right? The system is not set up to deprescribe. It's not easy to communicate changes once you've made them. The patients don't always know what medications they're on. I mean, there's tons of studies on why this is so hard and what the barriers are. We could have a whole episode just on, why it's so difficult.
Yeah. It does seem, though, there are barriers to taking your pills. You have to remember it. You got to pick it up at the pharmacy. Sometimes you have to pay for it. Sometimes you have to pay a lot for it. There's all of these also barriers that seem to be it's very hard for me to remember to take any medicine. But when it comes to these medicines like benzos and gabapentin and PPIs, man, people just stick with them.
I mean, some of them are very sticky, right? And we don't have a lot to offer sometimes other than a medication. So We don't have good access to physiotherapy. I'm from Canada. It's not necessarily covered or accessible for everybody. And so it is just so much easier to prescribe a pain medication than to get somebody into physiotherapy, just as an example.
Yeah.
Yeah, I'll say there are so many points at which deprescribing initiatives could have some benefit, but because it's so multifactorial, that's why it's hard to get people off medications. If you just focus on one point, then you're probably not going to address everything. Like there's no magic bullet, failure point that we could address here. The other thing just in my perspective, the other thing I'll say is what I've learned from these podcasts is that there's this big sort of cultural momentum towards prescribing in Western medicine. And there's so much work on, you got to take these medicines, you got to prevent this, treat that. There isn't that same sort of clinical momentum towards deprescribing. And I think of the analogy of like cancer screening, we got to prevent cancer. We got our pink ribbons, we're marching. Like that's the focus. The stopping the cancer screening doesn't have that same sort of momentum. I wonder if our guests feel that that's maybe sort of an underlying issue here.
Yeah, we definitely have a pill for every ill. Go ahead, Connie.
Yeah, I was just going to say that I think that there's certainly a lot of expectations, right? That these pills are going to do something. And so one of the things that we were thinking about is like, well, if we want to get people off of these pills, do you have to address those expectations? There are a lot of placebo effects out there, and there's a lot of expectancy that when you take this pill, it's going to help you. And there have been a lot of deprescribing studies for benzodiazepines and Z drugs where you're really targeting the pharmacological aspect, but not those expectancies, right? And so that could be part of it.
So you do a randomized control trial. You have your placebo group and your control group and your intervention group. Let's say it's a Z drug, and you see at like 2 weeks, both groups improved by, 30% on some symptom score for insomnia. We see this with like pain scores, like intervention after intervention. When you do these for symptoms, there's like a 20 to 30% response rate in the placebo group. Is that what you're talking about, Connie?
Yeah. And then for sleeping pills, it's even higher. There's this one meta-analysis that found that 63% of the drug responses were seen even in the placebo groups, 63%. And then there's like another study where they look at the placebo versus like no pill. So, and they were finding with the placebo group, there was a higher response than with no treatment. So, there's something going on there.
Mm-hmm. Man, I wish I had that because I took Ambien on a flight to Australia because I can't sleep on a plane, and I still can't sleep on a plane. Ambien does not help.
I just want to say a friend of mine took Ativan on a plane and woke up and got a DVT because she stopped.
Oh no!
That is.
I guess things could be worse.
Oh no!
So, Connie, you actually did a study looking at this placebo response, but instead of starting somebody on an insomnia pill and putting them on a placebo, it was kind of the opposite. Can you tell us what you did in your study?
Yeah, so we thought, well, if we want to get people off of the sleeping pill, then we need to try to tackle some of these mechanisms that are driving the placebo response. And so we had a randomized trial where one arm got a masked or blinded taper. So they didn't know exactly how much they were taking from night to night during their taper, Did they know they were being tapered at all? They did. So when we started off, we said, the overall goal is going to be to get you off, but they didn't know the sort of the rate of tapering. Uh-huh. And in addition to that, we also had specific cognitive exercises that were targeting sort of these expectations for the pill. And the comparator arm was a traditional taper where, we gave them a bottle and a pill cutter and a taper schedule. And both arms got what would be considered first-line treatment for chronic insomnia disorder, which is cognitive behavioral therapy for insomnia. So both arms got CBTI, but one arm got this blinded taper and the other got this open taper.
And the CBTI was slightly different, right, in the group that got the blinded taper?
Yeah, we call it augmented CBTI. So both groups got the standard, multi-component stimulus control, sleep restriction, et cetera. But the group in what we call the empty cap group, they got these additional exercises. And then also they had this special diary where we would ask them every night or the next morning, so how much relative to your baseline dose, percentage-wise, do you think you were taking?
Were they able to guess it?
Yeah.
So, some people were thinking they were taking more and others less. And we also include in this diary a list of questions for the next day to see how they were feeling and then also how they were sleeping. And during the sessions, therapists would try to, kind of probe at their expectations towards the pill. So if somebody said, I slept terribly, and they thought it's because you cut my dose, they'd be like, well, how do you know? How do you know? How do you know that was what was in there?
And you did that for what, 9 weeks, and the last week you actually told them what their dose was? Was that right?
Right. Yeah. So it was basically 2 months. And then at the end, there's what we call the unveiling. So then they would show their responses versus the actual. And there are, different patterns emerged as far as, some people were kind of overestimators, others under, and others were maybe closer. But, what we really wanted them to because it's there's the 2-month intervention, but then we were following them up 6 months after. So every time,
so 8 months after this, so you do 2 months and then 6 months after the 2 months? Or,
right.
Yeah. Okay.
So, every time they were going to go and take their pill, let's just say they were still taking it at the end, we wanted them to kind of question, okay, so what is this going to do for me? And how do I know?
Yeah.
Mm-hmm.
Did you have people drop out of the study because they thought they were being tapered when they weren't?
We actually had a really great response, follow-up rate. So most people stuck with it. I mean, of course, we did have some people who dropped out of an intervention, but didn't necessarily drop out of the study. So we're still able to follow them up. And yeah, I mean, I think for some people, it was anxiety provoking to not know exactly what they were taking.
I actually have a question to Emily, which is, how did you get people to sign up to begin with?
Right. Yeah. Actually, it was because both arms were getting treatment for their insomnia. I think it was really helpful.
The medication treatment or the CBTI treatment?
The CBTI. So that was helpful to keep people in the study, or to sign up rather.
I'm curious about what proportion got their group correct. How many knew that they were being tapered, and how many were wrong in that guess?
Right. So both arms, they were all being tapered off, but and we're actually still analyzing all of the different patterns in terms of which percentage tended to be overestimators versus underestimators. But I had a terrific MSTAR medical student working with me this past summer who was looking to see whether there were the type of medication, like the half-life, or was a Z versus a benzo, which factors were predictors of being overestimators or underestimators. And it turns out that none of the actual properties of the meds were predictors. So we're still trying to figure that out.
MSTAR, medical students in aging research. Apply now. I think the applications are due soon. Eric.
Okay, I got to find out what actually happened. So at 6 months, so really 8 months from the start of this trial, 6 months after you stopped the intervention, were people able to stay off the benzos?
Yeah, so we found in the empty cap arm, the mass tapering arm, 73% were off, and that's 6 months after they stopped.
3 out of 4.
Yes, it was great. And in the comparator arm, which was, they were getting basically 2 months of CBTI with an open taper, that was 59%. So we had a larger percentage in the empty cap arm who discontinued. Yeah. And it was significant. Both arms, their insomnia improved, which is great. I mean, they were off their meds and their insomnia
works.
improved. Yes. So,
I mean, those are pretty impressive numbers in both groups, highlighting that, you can stop these medicines. CBT does work, and your insomnia continues to improve.
And is it ethical to do a placebo taper in real-world clinical practice? Ethical and practical. I guess those are the questions.
Because you need like
Ought we
somebody
be doing
compounding the placebos too, right?
Yeah, so our study, we actually had a local compounding pharmacy, and I would write the prescription, which is that's actually a challenge because the amount of writing that goes on. I was writing paper prescriptions; it barely fit with my chicken scratch. But yeah, so we had a local compounding pharmacy prepare the meds, and the participants, they were okay with not knowing. So I think that's the key thing, right?
Yeah.
It wasn't like we just sort of did something on the sly. So as long as
But do you
everyone's
think you could do this in clinical practice? Like,
absolutely, yeah.
Yeah?
I mean,
Yeah?
yes. I mean, we had the local compounding pharmacy. We have patients or participants who say that they're interested. The Laura Carolyn, and big shout out to Dr. Carolyn, who she and I were sleep fellows together, and she's a psychiatrist in private practice, and she actually did the feasibility study up in Portland with a local compounding pharmacy with her private practice. We put it through IRB, but so it just shows that you can actually do this.
and people knew from an ethical standpoint, right? People knew that they were being tapered.
Yeah.
And it was a mask taper, but they didn't know when they were being tapered or how much they were being tapered. Is that right?
Right.
And I think it would be ethical in the real world because it's done already. It's done for allergy testing. Got a food allergen, they'll come in and they encapsulate and you don't know, but you're told ahead of time, you don't know if you're getting placebo or your allergen. So I think it is already being done.
That's a great point.
Okay, Connie, I got one last question about your article. The percent stopped was significant between the two groups, but the dose and the frequencies of taking these benzos weren't significantly different. Why is that?
Well, I think at post, one of those was significant, but there are so many people who came off of the meds. So if you look at if you're 0 versus 0.
yeah, it doesn't matter. All right.
I love that. So I guess one question then is, this was a pretty intensive thing. So you had these 9 weeks intensive CBTI therapy. You were writing these prescriptions. Is there another way for maybe more resource limited places? And this brings us to the question of patient-directed education. Emily, you did a paper looking at patient-directed-consumer educational brochures around gabapentin deprescribing. Do you want to tell us a little bit about what you did?
Yeah, so I'm the director of the Canadian Medication Appropriateness and Deprescribing Network, CADEN, and we had previously made brochures that we mailed out to people telling them how to get off their sleeping pills if they were interested. And so we adapted that brochure for gabapentinoids because there's a big problem of overprescribing of gabapentinoids in Canada and North America. I'm an internist, so when I hospitalize patients, 1 in 8 of my patients now takes pregabalin or gabapentin.
1 in 10 older adults in the U.S.
1 in 8, yeah.
No, in the U.S.
Yeah, in the U.S.
In the U.S., 1 in 10. Older adults, all older adults.
Yeah, it's one of the top most prescribed medications now. I, out of curiosity, sometimes I would ask my patients, do you know what this medication is and what it's for? A lot of times they didn't know why they were taking it. A lot of times they couldn't say whether it had helped them. So they didn't know if they were taking it for pain. They couldn't really say if it had improved their pain. So, we thought that was interesting. So we took these brochures and said, practically speaking, it is, again, we talked about it's hard to deprescribe in the clinical setting, acute care. That's where the study took place. Like there's a lot of competing work to be done. So we said, well, what if we just hand them a brochure and just let them know, hey, did you know you're on this medication? These are some of the things it gets prescribed for, but the evidence is not great that it helps people. Here's some of the harms. If you're interested, you're in the hospital right now, we can write you a taper. So just, mention to your doctor, mention to the team that you got this brochure, and here's even a suggestion for how to do it. So we did that and we compared it to just what happens, with usual care, which of course is not much. And, just found that this was a really easy, low budget way of, informing people about the medication, about the potential harms. And they were, a captive audience in the hospital. maybe even had come in with a complication, right, of the medication, maybe a fall or delirium.
Yeah.
Some complication that might have even kind of triggered that thought process about maybe it's time for me to come off of the medication. And just, we found that it was a pretty easy way to increase deprescribing just by giving out the brochures.
So low cost, there was 11% difference between the two groups, usual care versus, it was like 10% versus 21%.
Yeah, exactly. Yeah.
But limitation, this was not a randomized control study, right?
No, it was not. No, it wasn't a randomized control trial. We have, staff that circulate between the hospitals. And part of it is if the staff start to learn about it, there could be some contamination of your control. So we used patients who hadn't seen the patients from before and then patients from after got the intervention. So we did a control before and after study. So we kind of just looked at usual care up until we'd recruited a certain number of patients. And then we switched over and started doing the intervention so that there'd be no contamination.
And your deprescribing, was it on hospital discharge? How many deprescribed, or is it later on?
We looked at 8 weeks. Yeah. So we called people up at 8 weeks and they had to have either come off of it or have had a prescription in hand with a dose down to 0 eventually. So someone was intending to get them completely off of it, as opposed to like a dose reduction, for example.
Great. And in the adjusted analysis, number needed to treat of like 8?
Yeah. So we increased the absolute risk difference increase of 13%.
That is an amazing number needed to treat. Suggest we should be doing this, especially because it's low cost, low risk. Why aren't we? Or are we? Is this what's happening in Canada? I don't know. Emily, what's going on?
Yeah, we have them available now on the CTU. They're totally available online, and we've started translating them into multiple languages. We're starting to adapt them as well for different cultural communities. So it's a matter of, if you have a willing prescriber, if they're willing to print it out, it's there and you can do this.
So can our listeners download those right now?
Absolutely. Yes. Yeah. They're at the Canadian Deprescribing Network website. If you just Google Caden.
We'll have a link to that on our show notes.
Yeah.
Very well.
Wait, Alex. There's more.
There's more.
There's more. Because if you act right now, you can also look at 3 different drugs and patient-directed education on deprescribing PPIs, gabapentin, and other hypoglycemic agents. Is that right, Amy?
That is. Sort of right on the heels of Emily's work. We used essentially the same brochures in discussion with Caden. The PPI brochure, the hypoglycemia risk brochure, which was adapted slightly, which I'll come back to and explain a little bit more about the rationale behind it. And then we also had a gabapentin brochure, although it was created at the same time and albeit similar, was a bit more tailored to the VA and options that we had in the VA, because as Emily was saying about the healthcare system in Canada, to get into some of the non-pharmacologic ways of treating pain is a little bit more difficult. Within the VA, there's a program called Whole Health, which is really about trying to engage patients in many different modalities for pain management and just self-care. So acupuncture, Tai Chi, yoga, mindfulness, and physical therapy, chiropractor. And so those are all options that are available, and I can actually refer my patients directly to. So we wanted to look at gabapentin, but have it all these other options available. One distinction, though, is we only included, and I'll come back to some of how we did it and other differences, but we only included those taking 1,800 milligrams a day or higher. Mm-hmm. And so I noticed in Emily, in your study, it looked like it was around 600 a day as the average dose on the gabapentin. So we were looking at really high use and doses above 1,800 milligrams per day. And I have seen patients of mine prescribed 4,800 milligrams per day. There's like no extra benefit with just a whole lot of extra risk. And so we were really just looking for the patients who are at like doses beyond what they're going to get any benefit from and trying to get them to a safer dose. And so we were interested in the gabapentin from that perspective. And then the other that we were really interested in was for diabetes. And we were talking a lot at the top of the hour about a lot of the patient-related barriers to deprescribing. But I think there's a lot on us. And I don't necessarily think that we're doing anything with ill intent, because we want to do right by our patients. And there's something that feels better about doing something than doing nothing. especially if someone is on something and hasn't had a side effect, then you're like, oh, you're fine with it. So we really wanted to address this risk for low blood sugar in older adults with diabetes who had an A1C below what we would consider like safe for that age, and taking 2 medicines for diabetes that are pretty decent risk for landing you in the emergency department with low blood sugar. Not to say like to not treat diabetes, but to not
what
use
were
the
those
high
2
risk.
medicines?
So insulin, which is the injections, and then sulfonylurea. So primarily in our study, glipizide.
And that was a hemoglobin A1C of like less than 7?
Less than 7. They also had to have at least also done one of the following: older than age 65, or cognitive impairment. Because again, like we're asking patients who their time to benefit with some of these medicines also is not necessarily there, and the risk is much higher, or renal problems, kidney problems. So these are like really, 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 really well treated, to the point that the risks are probably now.
But they didn't have to have a hypoglycemic episode yet.
Exactly.
Okay.
So the whole thing is we want this to be proactive. Like, let's get people to stop taking the risky medicines before they land in the emergency department.
Yeah.
But honestly, a large part of the diabetes part we think is a little bit more on the clinician, right? When you start someone on insulin or diabetes meds, you really, really instill in the patient, like, oh, you have to take this every day. You probably take it for the rest of your life. There's no exit ramp. And so we don't prime patients to think about stopping in the future. And there are metrics about how clinicians get evaluated in terms of their diabetes that people misinterpret of what those metrics are. And so we just keep going. And so we really wanted to have a medicine group that was around, that we thought was a little bit more driven by the clinician behaviors and a little bit less about the patients. And so that was the main adaptation that we did for that one.
And this is in primary care, right?
Right. So we did primary care, maybe egocentric. I'm a primary care doc, but we also, most routine prescribing, most, renewals, chronic meds, they're going to be happening in the outpatient setting. And what we really wanted to do was make this to not interfere with the clinician. So it was extremely low touch for the clinicians. It wasn't a clinical reminder. There was no pop-up. There was nothing that blocked you from proceeding in clinic. And essentially, we mailed the brochures to using, old-fashioned postal mail. We think they arrived. And they were sent about 2 to 3 weeks in advance of an upcoming primary care visit. And that was intentional. We didn't want to just do a blanket, send it to everybody on, in the clinic who might be eligible, because that might inundate the clinic with phone calls or questions of like, why am I getting this brochure? Why is this, medicine potentially bad for me? So we really wanted to time it in advance of that clinic visit so they could come in and raise the question with their clinicians. And similarly, so we looked for our outcomes at 6 months and essentially either stopping the medicine or just going down on the dose counted. And at 6 months, we found success across all the groups, about 1.2 times the odds for deprescribing in the group that got the intervention compared to those who did not. There was no difference across the different medications in terms of the effectiveness of the brochure. And what I will say, separate from the brochure, though, if we were just to look at the medication groups and like how they thought about or what their rates of deprescribing were, the biggest deprescribing rates, although it was the smallest group, was actually in that high dose gabapentin group.
Huh. And deprescribing as far as anything. You could stop it, but you could just go down on the dose.
You could go down on the dose. The only, because of technical measurement issues, the insulin one was you either had to stop it or continue. There was no dose reductions just because it's really hard to capture in prescribing data how much people are taking.
Mm-hmm. And how big of a magnitude is this? What % of people actually had some deprescribing in the two groups?
We actually had a really high, higher than expected baseline rates of deprescribing of about 25%. And then it went up to about 29% in the intervention group. But that absolute difference of 4%, and we know, at least in the PPI group, the proton pump inhibitor group, those are so overprescribed that even if we're just talking about a small absolute, magnitude difference here, at the population level, it could save people from taking meds that they're not getting benefit from, they're potentially getting risk, and save, their effort, our effort, and let us focus on the meds that probably matter more for their continued health.
And did you consent people for this study?
We did not consent. It was done as a pragmatic trial because we weren't changing the medicines. All we were doing, providing information. And we did give a brief overview via email to the clinicians, basically saying, hey, your patients might come in with this. Here's some information about deprescribing. Here's some information about these medicines. You make the clinical decisions. We cannot tell whether it's appropriate or not completely from administrative data. We just want to educate the patients, and now you guys can make a more informed decision about whether you should or shouldn't continue this medicine.
Any pushback from the clinicians or the patients?
No, we got very little pushback from clinicians, to the extent that when we tried to interview them afterwards to see how it impacted their practice, very few clinicians remembered, even were aware that this had happened, because it was so minimally invasive with their clinical practice. We did do a survey of patients afterwards, and but more to understand how they felt getting the brochure, whether that led to them talking about their medicines. Basically, were we able to activate patients to be more engaged in their healthcare and healthcare decisions?
I got a question for all three of you then. So on one hand, you have Connie, high touch, high yield. 70-something% deprescribing, like a huge deprescribing, versus Amy and Emily, kind of low touch. You're just sending it out as brochure, smaller yield. What's the right approach? Or is it both? Thoughts on that? I'm going to open it up to the group.
Yes, both. Why not?
But is there a group that you should target more for the high? You can't do high touch for everything.
But I think your first wave is, Amy's and my approach, right? And then maybe you have other people who are more resistant or who need more oversight for their taper, or who maybe they've tried it out and said, listen, I tried, but that 8-week taper, that one size fits all you have, it's not for me. It was too fast. I need more support. So then you need to go to the more high touch intervention, I think. But you could just start as a first wave, using the brochure and see what you catch. But for sure, there's going to be people who need Connie's approach.
Yeah, I love that. Connie, would you agree?
Yeah, I think there's definitely a need for, a variety of different approaches. It's interesting because we had another study using a low touch approach. We mailed out the Empower Like brochures to within the VA, but we also, it was a randomized control trial. So we mailed out just some general information about sleep with a link to a site that was just information about sleep. And the Empower brochure was enhanced with a link to online CBTI that's sort of free and anonymous. And we unfortunately did not find a significant difference. Not sure why. It was during the height of the pandemic. Could have been, people weren't seeing their providers. But I do think though that there's still a role for a low touch, medium touch, high touch.
Well, and Justin Turner mailed out the brochures in the province of Manitoba for opioids, right? This study was published, I think, maybe 6 months ago, and that did not work. So, big population level study using the brochures, and there wasn't really a significant difference in deprescribing of opioids. So, the medication class might matter as well.
Yeah. Well, speaking of medication classes, we have some drugs, probably all of us are in agreement, worthwhile stopping. You got your benzos, you got your gabapentins, you got your PPIs. We have other drugs a lot of people are taking, like antihypertensives, that, if you look at the SPRINT trial, older adults, improves lots of outcomes, including mortality, potentially cognition. But is this an area that we should also be thinking about deprescribing, especially for older adults? And that brings us to our last study, Michelle. Michelle, you looked at this for nursing home patients, deprescribing antihypertensives. Is that right?
That's correct. Yes. As you've said, we know blood pressure control is a cornerstone of cardiovascular prevention and even dementia prevention in midlife and even in older age.
Everybody gets their blood pressure checked. Very first thing you do when you visit a doctor's office, weight and blood pressure.
Absolutely. I would say it's probably the most measured physiologic parameter and strangely still one of the least understood, especially in older adults with multiple chronic conditions.
Because Sprint actually excluded people in nursing homes. So we don't have any good data on blood pressure control in nursing home patients, so frail or older adults.
That's correct. So Sprint excluded nursing home residents, people with dementia, and of course, diabetics. So a huge proportion of the group that I'm interested in studying, and that is people who are older adults with multiple chronic conditions, frailty, who often reside in a nursing home.
Yeah. So you looked at this population. What did you do in your study?
So we did a little different study design than the other articles we've heard about today. So we did a completely observational study. We were trying to mimic or emulate the trial that we would like to do. So of course, we'd love to do a large randomized controlled trial where we randomize people to either maintain their antihypertensive regimen or deprescribe. But this can be a difficult population to enroll in RCTs, primarily because of the vulnerability of the population. You know, they have a lot of chronic conditions. They might not be able to complete the trial protocol. So we leveraged observational data in which there's already a lot of deprescribing happening. In our early studies in the same nursing home population, we found about 70% of residents had a deprescribing event of antihypertensives during their stay. And that was a stay of a median length of 6 months. So we're seeing that there's a lot of deprescribing happening of antihypertensives in this population, but very little RCT evidence to tell us about the benefits and harms of that deprescribing. So in our study, we used observational data to observe residents who were deprescribed, and that's a reduction in dose of 30% or more, or a reduction in the number of antihypertensive medications. And then we used statistical methods to try to control for differences in the characteristics of people who deprescribed and did not deprescribe, because of course it's a non-random event. So that's where we have to turn to our friends of statistical models to try to balance the things that might lead someone to deprescribe. And so we used all our best methods available, and we found that those residents who deprescribed their antihypertensives actually had a little bit of a slowing in their cognitive decline. And we saw that slowing of the cognitive decline was even stronger in those with dementia. So the effect size was pretty mild. It wasn't something that, I think should be necessarily used as a cognitive preservation intervention. But we at least know that this is reassuring for providers and patients who are interested in deprescribing, that we can say it looks like we're not seeing any harm for your cognition, and it might even improve cognitive function.
Huh. And there was another study, right? A very like a 14 or 16-week study looking at deprescribing antihypertensives in the nursing home. Was it a randomized control study? I think you mentioned it in your discussion section too.
Yeah, there have been a couple studies. There have been the Dante trial as well as the Optimized trial, and both have shown really no harm in deprescribing antihypertensives. There was a newer trial, which it was a little less conclusive. It's called Danton, and it was just published mid 2024. And unfortunately, that trial was stopped early because of some current concerns about increased adverse events in the deprescribing group. And that was also in nursing home residents. So, I think if anything, all of these, the small amount of evidence that does exist is just highlighting the uncertainty and the need for more randomized controlled trials and more high quality observational studies of deprescribing to help providers and their patients make this decision.
Could we because you're an expert epidemiologist and have explained things to us in our division clearly in the past. I remember you explaining, I think, inverse probability treatment weighting at some point. This was this was like a target trial emulation. Is that the right? Emulated target trial? Is that the right words? And can you explain this to our readers? Our listeners and readers. Some people read emails. Yeah.
So as I mentioned, in an ideal world, we'd like to do a trial, but in situations where a trial is not feasible for multiple reasons, or it just simply hasn't happened yet, we can use observational data to emulate the trial we would like to do. So a couple things make this different than like maybe some of the observational studies that you'll see in other settings. One is that we always want to be studying a change, right? So in this case, we were studying the people at the moment of deprescribing and looking at those who deprescribed versus those who maintained their antihypertensive regimen. And the reason we want to be studying a change is because we need to control for the pre-change characteristics that led to that change. And in epidemiology, we call those confounders. And so we need to be able to look temporally at what happened before either the person deprescribed or stayed in their treatment group. And then again, we use statistical methods to try to control for those differences. So that's one feature of a target trial emulation, is that you're looking at longitudinal data and you're looking at controlling for confounders before some change was made, and then looking at events that happened after that change.
Now, is that an advance over like great observational methods, or is this like observational data dressed up to look like a randomized trial?
You could say that target trial emulation is just a well-conducted epidemiologic study. Like there's nothing magical that makes it target trial emulation. It's just a collection of design principles and analytic methods that try to mimic a trial in thinking about things like selection, the time of initiation or change in medication, looking at the length of follow-up and looking at, well-defined outcomes. So there's nothing magic that puts it into the target trial realm other than this like set of principles of design and analysis.
Yeah. And in defense of emulated target trials, you're using real world observational data. If you had a randomized trial, it's likely that there are some patients who would not agree to participate, or who you might exclude from that trial, who you would include in an observational data set of patients with multimorbidity, dementia, residing in nursing homes.
But it also comes at the cost, right? That fundamentally there's a difference between the group of people we decide to stop these medicines and the group that we decide to continue them on.
And you don't think you can balance all those things?
You really
You can balance for the Donald Rumsfeld. I heard that Stephen Colbert talked about this last night. You can balance for the known known knowns, but you can't balance for the known unknowns that you can't measure, or the unknown unknowns. And if it was a real randomized trial, it would be sorted. The reason Stephen Colbert was talking about it, by the way, is because he said there's another category called
unknown unknowns.
Unknown knowns, which is when we know something because we had the same president previously, and then we unknew that. Michelle, thoughts about randomized trials?
Not your thoughts about Donald.
I don't want to tackle politics, but we're all taught that randomized controlled trials are the pinnacle of evidence because of this key feature of randomization, balancing, confounding. And yes, that's a wonderful feature that is critical for causal inference. But the huge limitation, as you alluded to, is that randomized controlled trials, even the best designed RCTs, don't represent real world patients. If you look at Sprint, for example, Sprint represented a fraction of the community dwelling older adults who are actually indicated antihypertensive medication. And so even though Sprint was an exceptionally well-conducted trial, the results might not apply to community dwelling elders and especially nursing home residents because they didn't include any nursing home residents. And we know, that the calculus of benefits and harms depends on characteristics of the patients. So I think RCTs have been oversold to us a little bit because of this nice feature of randomization. But what we're trading off for that is selection bias. And, I'm not a clinician, but from what I hear from my clinical colleagues is they're concerned about treating patients to guideline level standards when the guidelines were derived from RCTs that don't look like their patients. Mm-hmm. And that was really what motivated me getting into this research, is wanting to help my clinical colleagues make better decisions when they didn't have evidence in people that looked like the patients that they were prescribing for.
I love it, Michelle. I'm wondering if I could turn to all four of you now, kind of magic wand. If you had a magic wand, after listening to everybody else's articles and then doing your own, what would you use that magic wand on around the issue of deprescribing in older adults? Connie, I'm going to turn to you first. We'll go in order of how we did your articles.
Gosh, it's so hard. I mean, I feel like there's so many different factors, right? So I would want to, I think targeting the prescribers, really trying to reach out to the patients, doing both at the same time. Does my wand cover like the full spectrum?
It can cover big or small. So what would you do if you were focused on the prescribers? How would you reach out to them with the wand?
I mean, for me, I'm really kind of intrigued by this placebo effect. So I would want to see where we can tackle that more, right? And try to see how we can leverage, mass tapering or, trying to target expectancies. That would be my thing.
That's great. All right, Emily?
I think I'd go for the public, big multi-million-dollar campaign just to make people aware that medication isn't the answer, that, every medication has side effects, that if you can, for some of the conditions we've talked about today, that, you'd want to do what you can to avoid medications if it's safe to do so, and really just increase the public's knowledge on this topic. I think I love it. For every drug company ad, there has to be another drug company sponsored pharma deprescribing ad talking about why you should stop this drug. Yeah. Big public awareness campaign.
It's great.
Amy?
I think mine actually approaches both the patients and the clinicians. I would want to change sort of people's psychological comfort with this idea that if you stop something or reduce something, not only might you have no additional harm, like Michelle was showing, but that you can also actually have benefit. That this isn't going to be we're taking something away and you're going to do worse. We're taking something away and there's a lot of benefits that go with it, and it's worth trying that.
Wonderful. Michelle?
I'm going to go really big with my magic wand. I think kind of like we were talking about at the beginning of the show, I think a lot of resistance to deprescribing comes from the fact that our society is fairly ageist and we don't really want to talk about or understand the changes that happen in bodies when they age. So I think if we could just embrace aging as a change that happens to all of us, should we be fortunate to go through it, we would be more open to deprescribing that accompanies that.
That was great. Love the magic wand. How about a little bit more pink?
Where I can run just as fast as I can to the middle of nowhere, to the middle of my frustrated fears. And I swear you're just like a pill. Instead of making me better, you're making me ill. You keep making me ill.
Thank you all for being on this podcast. Learned a lot. Love the work that you're doing.
So creative too. Thank you.
Thanks for having us.
Thank you. Had a great time.
And to all of our listeners, thank you for your continued support. We'd also like to thank everybody who's donated over $250 to the podcast over the last year, including
Daryl Owens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Strait, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones. Thank you all.